Hello everyone, and this is the daily quiz series in the run-up to the NEETPG 2025. We are in week 3. We are covering general physiology and muscle physiology in this week. In the previous 2 weeks, we have already covered CNS, nerve physiology, cardiovascular system, and respiratory systems. So let's have a look at the first question now. It says, which of the following is relatively unchanged during a muscle contraction? Now, when I look at a muscle, between the two Z lines, we have the structural and the functional unit of the skeletal muscle, which is called the sarcomere. Attached to the Z line is the thin filament, which is actin. And then we have the thick filament, which is myosin. Now, which are the bands which are present? The A band, or the dark band, it consists of myosin plus the overlapped actin. Within the dark band, we have a slightly lighter area, which is called the edge zone, and edge zone is only myosin. On either side of the A band, we have the light band, which is the I band, which is only actin. Now, what happens during a muscle contraction? The I band will slide into the A band. So what happens to the I band? It reduces. What happens to the edge zone? It decreases or sometimes even disappears. But what happens to the A band? This is unchanged during a muscle contraction. So my answer to this question becomes A band. Let's see the next question. Now, this is a pacemaker potential. We know in the heart there are two types of potentials, the plateau potential, which is recorded from the contractile cells, and the pacemaker potential from the SA node and the AV node. Now, the pacemaker potential has got 3 phases: phase 0, phase 3, and phase 4. Phase 0 is known as the depolarization phase, phase 3 is the repolarization phase, and phase 4 is known as the prepotential phase. Now, the depolarization phase in the pacemaker potential is because of a calcium influx, and the channels involved are called the calcium L channels. There are 2 tissues in which the depolarization is because of calcium influx, and that is the pacemaker cells and the smooth muscle cells. In all the other tissues, the depolarization is due to sodium influx. In a neuron, skeletal muscle, cardiac muscle, depolarization is due to sodium. Repolarization everywhere is because of a potassium efflux. Now, what happens in the prepotential phase? In the prepotential phase, the cell goes from more negative to less negative. There is a slow and spontaneous depolarization from the resting potential of minus 55 to the firing level of approximately minus 45. How does a cell go from more negative to less negative? By gaining positive charge. And there are 3 mechanisms by which the cell will gain positive charge. Number 1, there is a decrease in the potassium efflux. The potassium efflux in phase 3 reduces, so cell will gain positive charge. There is a opening of what are known as the funny channels, which permit the movement of both sodium and potassium, but the movement of sodium predominates, so net gain of positive charge. And number 3 is a calcium influx through calcium T channels. These 3 mechanisms will cause a net gain of positive charge, and the potential of the cell will go from more negative to less negative. That is the prepotential phase. Answer to this question, of course, is A, calcium influx. Next, a 55-year-old woman has a plasma potassium of 6.1. So this is definitely elevated. How much is normal plasma potassium? This is 3.5 to 5 milliequivalents per liter. Now the question says, how does this affect the equilibrium potential for potassium and the resting membrane potential. So let's try and understand that. Now, equilibrium potential is calculated by the Nernst equation. And what is this Nernst equation? The equilibrium potential for potassium in millivolts or for any ion in millivolts will be 61.5 log of C1 over C2. What is C1? Higher concentration divided by lower concentration, right? So normally, in the case of potassium is in a higher concentration inside the cell, approximately 140, and lower concentration outside the cell, so about approximately 3.5 to 5, right? So C1 here is 140, C2 here, let's say, is 5. But now, in this question, the outside concentration is increased to 6. That means the gradient has reduced, right? So now we will see that normally if the equilibrium potential for potassium is minus 90, if C1 by C2, now C2 is now higher than normal, and if you take the log, we find that the equilibrium potential for potassium will be lower than minus 90. That means it may be minus 80, minus 75. You will have to do the math and calculate. So it will be less negative equilibrium potential. Now, what will happen to the resting membrane potential? Now, what is the reason for the resting membrane potential? The cell membrane at rest is almost freely permeable to potassium. Higher potassium inside the cell, less outside the cell. Potassium tends to move from inside to out. Inside is losing positive charge, so it develops a negative potential relative to outside. Right? But if this gradient reduces, why does it reduce? Because the outside potassium is now more than normal. Right? So the gradient reduces. There is less tendency of potassium to leave the cell. That means the resting membrane potential will be less negative. Yes? So this will cause a less negative resting membrane potential. A less negative equilibrium potential and a less negative resting membrane potential. Look at it conceptually. If the gradient reduces, less tendency of potassium to leave the cell. So more positive charge inside the cell will cause a less negative equilibrium potential and a less negative resting membrane potential. On the other hand, if there was a hypokalemia, more tendency of potassium to leave the cell. More loss of positive charge would mean inside will become more negative. In that case, my answer would have been more negative equilibrium potential and more negative resting membrane potential. So let's see this. This is less negative equilibrium potential and a less negative RMP. How much is a normal plasma colloid osmotic pressure? This is a factual question. This is 25 to 28 millimeters of mercury. Right? And what is the colloid osmotic pressure? Colloid osmotic pressure is due to proteins. How much are the normal proteins in the plasma? Normal proteins are 6 to 8 grams per deciliter. In terms of millimoles, this is 2 millimoles per liter. All the proteins put together are only 2 millimoles per liter. In terms of grams, 6 to 8, but in terms of millimoles per liter, 2 millimoles per liter. And their contribution to the osmotic pressure is 25 to 28 millimeters of mercury. Remember, colloid osmotic pressure is only due to proteins. So if I ask you a question, which protein is primarily responsible for the colloid osmotic pressure? Your answer will be albumin. Why albumin? Because this is the most abundant protein in the plasma. So albumin is the primary protein responsible for the oncotic pressure or the colloid osmotic pressure. As part of an experiment, radio-labeled ATP is injected into the skeletal muscle. During muscle contraction, the labeled ATP is observed to attach. So when the ATP attaches to the myosin head, this causes a detachment of the myosin head from the actin molecule. If you look at the actin-myosin crossbridge cycling, at rest, the myosin head is in a high energy, high affinity state, ready to bind with actin, but cannot do so because of the active sites on actin are covered by tropomyosin. So as soon as calcium becomes available, it combines with troponin C, which causes tropomyosin to slide. The active sites on actin are exposed, and the myosin head will bind with this active site on actin by reversible bonds. The myosin head will use this high energy and execute what is known as a power stroke. Next step is ATP attaches to the myosin head. And the moment ATP attaches to the myosin head, it causes a conformational change and causes detachment of head. And once the head is detached, now the ATP which had got attached to the myosin head, it now will be hydrolyzed. So there is a hydrolysis of ATP, energy will be generated, and the myosin head goes back into that high energy, high affinity state. If calcium is available, it will now bind with the next active site on actin, again execute a power stroke, ATP attaches, conformational change, detachment of head. ATP is hydrolyzed, head goes back into high energy, high affinity state, and again binds with the next active site on actin. This is how cross-bridge cycling will take place. Remember, this cross-bridge cycling is responsible for sliding of the actin over the myosin. And this cycle will continue till calcium is available. Once calcium goes back into the sarcoplasmic reticulum, the muscle will stop contracting and relax. So answer to this question is B.